So, all right then, everybody, welcome back to the webinar after your break. Hope you've had coffees and little tidbits. Sorry, I was eating in the middle. I apologize. But essentially, our next presentation is going to be by Mr. Jayaprakassan. Mr. Jayaprakassan is one of our consultant gynecologists with a subspecialist in reproductive medicine and minimal invasive surgery. He is currently working with us at Royal Derby and is part of our fertility unit. Unfortunately, he is busy with a theatre session that he had, but we've got his presentation, so we can start the presentation and then we can take up questions afterwards. Hopefully, he will be available for those. So I'm going to start the presentation now, everybody. Thank you.
Hello, everyone. First of all, I would like to thank the organizing team, Sumi Abdul, Professor Saad Ahmad, Subul, and Nilofer for inviting me for speaking at this nice symposium. Hope you're all enjoying and having a good day. We know endometriosis is quite common and it has got significant impact on fertility. And if you're looking at the evidences, unfortunately, there are
Has it frozen the video, Subul? Subul, can you hear? You're muted, Subul.
Let me start again.
for speaking at this nice symposium.
Is that better?
Enjoying and having a good day.
Yes, yeah.
We know endometriosis is quite common and it has got significant impact on fertility. And if you're looking at the evidences, unfortunately, there aren't any concrete evidences in this area, and I will go through with you regarding this. But one thing that we need to remember is absence of evidence is not the evidence of absence. Having said that, I have looked through a number of articles, guidelines published in the literature, including the recent ESHRE guideline, which was published last year. So my plan for the next 20 minutes is initially looking at the association between endometriosis and fertility, that's natural conception as well as following IVF, and then looking at the effect of surgery on the conception either naturally and following IVF. So first of all, endometriosis is quite common in women of reproductive age, probably around 5 to 10%. And if you're looking in the subgroup of fertile population, it would be lower compared to nearly about 25 to 40% in infertile or subfertile women. And women undergoing, subfertile women undergoing laparoscopy, the prevalence of endometriosis is seen in about 30 to 50% of women. Now, looking at the association between endometriosis and natural conception, this is a
Start and run it forward.
subdivide them into mild, moderate, and severe. Around 50% of women have conceived in the mild endometriosis group, and the moderate endometriosis group, about 1 in 4 women conceived, and they did not find any conception in women with severe endometriosis. So certainly the endometriosis affects fertility, and the effect vary depending on the endometriosis grade. So how endometriosis can affect fertility? And you can divide that into 3 components. And one is the oocyte-sperm interaction, and that may well be related to the anatomical disturbance or disturbance in the anatomical relationship between the tube and the ovary, and therefore it can potentially impact the sperm-oocyte interaction. In addition to that, there could be inflammatory changes in the peritoneal fluid, which are not favorable for the sperm and the oocyte quality and interaction point of view. And there is a hypothesis that it can affect endometrial receptivity due to possible activation of steroidogenic factors and therefore increased estrogen within the target organs like endometrium. Endometrium may potentially have resistance to progesterone, therefore affecting the endometrial receptivity. And endometriosis can affect ovarian reserve, both quantitative and qualitative aspects, and therefore potentially reduce the chance of natural conception as well as probably following IVF. Having said that, whether IVF will bypass the oocyte-sperm interaction, and we'll see what the data shows. And this is a systematic review published now just over 20 years ago. And that has shown in this forest plot that can affect the presence of endometriosis can reduce the chance of IVF success by about 20%. And in that study, they have categorized into stage 1 and 2 endometriosis. And when they compare stage 1 and 2.
Sorry, everybody. Let me try this one more time.
Around 50% of women have
Can everybody
in the mild endometriosis.
Is that moving now?
And it's a moderate
All right, I'll just keep the screen as it is. I won't.
And they did not find any conception in women with severe endometriosis. So certainly the endometriosis affects fertility, and the effect vary depending on the endometriosis grade. So how endometriosis can affect fertility? And you can divide that into 3 components. And one is the oocyte-sperm interaction, and that may well be related to the anatomical disturbance or disturbance in the anatomical relationship between the tube and the ovary, and therefore it can potentially impact the sperm-oocyte interaction. In addition to that, there could be inflammatory changes in the peritoneal fluid, which are not favorable for the sperm and the oocyte quality and interaction point of view. And there is a hypothesis that it can affect endometrial receptivity due to possible activation of steroidogenic factors and therefore increased estrogen within the target organs like endometrium. Endometrium may potentially have resistance to progesterone, therefore affecting the endometrial receptivity. And endometriosis can affect ovarian reserve, both quantitative and qualitative aspects, and therefore potentially reduce the chance of natural conception as well as probably following IVF. Having said that, whether IVF will bypass the oocyte-sperm interaction, and we'll see what the data shows. And this is a systematic review published now just over 20 years ago. And that has shown in this forest plot that can affect the presence of endometriosis can reduce the chance of IVF success by about 20%. And in that study, they have categorized into stage 1 and 2 endometriosis. And when they compare stage 1 and 2 with the control group, the pregnancy rate has affected. And if you're comparing stage 3 for endometriosis versus the control group, again, there was in fact even more profound decline in success rate following IVF. And if they have compared stage 3 and 4 versus stage 1 and 2, again, there was a difference. So this study showed that the IVF success rate can be reduced because of the presence of endometriosis, and the degree of impact vary depending on the severity of the endometriosis. But when we are looking at the more recent systematic reviews, and this is the one which is published just about 10 years ago, and that study has shown And in fact, they have categorized into stage 1 and 2 and compared that group with control. There was no difference in terms of clinical pregnancy rate, but more severe cases, there was a profound decline in the IVF, in the clinical pregnancy rates following IVF. But when they looked at the live birth rate as the outcome, they did not find that observation. And in fact, moving away from systematic reviews, a much more larger study, although it is a retrospective data from US, the SART data, and look at this, the number of women with endometriosis only, and if they are when they are compared that group with the unexplained and the human factor, the live birth rate were more or less similar. So you can see that in the endometriosis group, with the fresh embryo transfer cycle is 45, and with the unexplained, it's more or less similar. In fact, it is 41. And if you're looking at the frozen embryo transfers, it's about 35 and 33.7. So in the more recent retrospective study from US has shown that there was no impact on endometriosis or IVF outcome. And the two factors that we said about endometrial receptivity, and the other one is whether the endometriosis affected egg quality. So therefore, the researchers have looked at whether endometriosis would affect the embryo quality, because obviously if it is affecting a quality, that would potentially impact the embryo quality. And people have looked at the biopsy, the embryos, and looked at the chromosomal pattern to see whether there is an increase in aneuploidy rates. In other words, this study has looked at the euploid rate, and they have categorized depending on the age, and there was no difference in the euploid rates in women with endometriosis compared with the control group. And exactly similar sort of outcome I've seen in two subsequent studies as well. And then this has gone a little bit further, whether endometriosis affect the endometrial receptivity. And where they have, in this study, they have transferred the euploid embryos into women with endometriosis. And when they have compared with endometriosis group with male factor, there was no difference in terms of the clinical pregnancy rates. And therefore, you may potentially, or we may potentially conclude that the chances of endometriosis affecting the endometrial receptivity is probably lesser as we thought based on the previous studies. Having said that, we just have to accept that in the frozen embryo transfer study that I've shown you, they have used ovarian suppression using a combined pill, and therefore whether ovarian suppression for a short period of time would make a favorable impact on the endometrial receptivity. So that may well be a cause for a finding of similar pregnancy rate in their study. And also that based on the equivalent euploid rates in both the endometriosis and the control group has potentially indicating that oocyte quality may not be affected in IVF. What about presence of endometrioma? Again, there has been some nice systematic reviews, and they have shown that the live birth rate is not affected following IVF, whether there's endometrioma or not. Having said that, there have been increased in treatment cancellation due to low ovarian response to control ovarian egg stimulation, and also the studies have shown that the low number of eggs collected. And a subsequent, another systematic review have also shown more or less similar findings, with the number of eggs collected is reduced in women with endometrioma. And that shows that probably the endometrioma reduces the ovarian reserve, and therefore, therefore having a low ovarian response to controlled ovarian stimulation during IVF. So we could conclude based on these studies that endometriosis reduces the chance of natural conception, and that may possibly be related to oocyte sperm interaction. From the IVF success point of view, the old data indicate conception following IVF is reduced. However, recent data shows that the IVF success rates may not be affected. And also there were findings of no effect on euploid rates, and possibly no effect on endometrial receptivity. But as I mentioned, that the frozen embryo transfer cycles have used ovarian suppression, and therefore the endometrial receptivity probably would have been improved with the ovarian suppression in women with endometriosis. Endometrioma has not shown that the IVF success has not shown to affect the IVF success rate, although there has been a low number of eggs collected. So whether the treatment affect fertility chances following natural conception or IVF for endometriosis, and we know that there are various management options, expectant, medical, surgical, and combined approach, and the treatment guided by various factors. And of course, that we'll have to consider age, symptoms, and what their current ovarian reserve is, and other fertility factors. And in this study, this is a Cochrane review, and they've looked at giving any medical treatment like combined pill or a GnRH agonist for a short period of time, and then following stopping those, whether the pregnancy rate would improve. And this study has shown, the Cochrane review has shown that there is no improvement. So that means no benefit for the medical management. What about using medical management preoperatively and postoperatively? And again, this systematic review has shown that if you are giving preoperatively, that hasn't shown any improvement in terms of pregnancy rate. And following surgery, if you're giving medical treatment, that probably has shown a trend towards improving pregnancy rate, but that is not significant. And if you are giving medical management, particularly the combined pill or GnRH agonist, soon after surgery, they are missing that period of time because obviously these are all contraceptive. But on the other hand, if they are not trying to conceive, the studies have shown that it improves the pain, and therefore this is something that can be adopted. What about surgical treatment for mild endometriosis? This is a nice randomized controlled trial where they have diagnosed the mild endometriosis, and they have either excised or diathermized of the endometriotic implants, and they followed women for up to 9 months, and you can see that the pregnancy rate was better in women who have had a laparoscopic treatment. And in fact, you can see that the pregnancy rate has been going up to about 6 months, and then it reached a plateau. So we could, based on this, we could advise women that are following surgery, it is best that they try to conceive as soon as they are fit. And then up to about 6 months, and you think about moving up the ladder for other treatment like IVF after 6 months of natural attempts. What about the comparison between? Sorry, this is again showing clinical pregnancy rate. This is a systematic review of studies, comparison of ablation or excision versus diagnostic laparoscopy, and that has clearly shown that the pregnancy rates are better. And however, when they looked at the miscarriage rate, they were similar between the two groups. They have looked a little bit further in terms of the pain control of ablation versus excision, and there isn't any sort of improvement in terms of pregnancy rate or pelvic pain. But later follow-up at 5 years, they have shown that the greater reduction in dyspareunia in the excision group. What about treatment for moderate to severe endometriosis? There was no controlled studies, but there were some uncontrolled cohort studies, and the studies have shown that the pregnancy rate, spontaneous pregnancy rate following treatment for moderate to severe endometriosis has been over 50%. So that's quite a significant pregnancy rate that we could expect if women had subfertility and moderate to severe endometriosis. And the major benefit would be soon after the first attempt. But obviously, surgery for moderate to severe endometriosis is not as simple, and even with appropriate expertise, there's more risk of complication and quality of life. So the operative laparoscopy could be considered for women with symptoms. So the ASHRAE guideline recommends in stage 1 and 2 endometriosis, operative laparoscopy, including endometriosis, can improve ongoing pregnancy rate. This is a weak recommendation. However, in deep-seated endometriosis, operative laparoscopy may represent a treatment option in symptomatic women wishing to conceive. Decision to perform surgery should be guided by symptoms, particularly the pain, age, history of any previous surgery, other infertility factors, of course, the ovarian reserve, and the predicted endometriosis fertility index, which is a concept that has come up in published in 2010. And this is similar to American Fertility Society AFS or ASRM score, but they have considered, other than the operative findings, some other historical factors. That means age, years, infertile, and prior pregnancy. So basically, following surgery, they have looked at the degree of dysfunction of the fallopian tube, the fimbria, and the ovary. And the normal is given a higher score, and absent or non-functional structures are being given a score of 0. And then finally, you come up with a surgical score, as well as the score based on the history, and you get the total endometrial fertility index score. And higher the EFI score, higher the chance of natural conception. So that helps us in terms of counseling women about their prognosis from the fertility point of view. What about endometrioma and spontaneous conception? We know that the endometrioma is not uncommon in women with endometriosis, and the studies have shown that the ovulation rate when comparing the affected ovary with the normal ovary, the healthy ovary, the ovulation rate has been similar in the larger recent study, although the previous smaller studies have shown, yes, it could affect your ovulation. With regard to the surgery point of view, there aren't any controlled studies looking at the natural conceptions, although surgery for endometrioma may restore the pelvic anatomy and potentially improve the pregnancy rate. However, there are certainly concerns on reducing the ovarian reserve and, in fact, even remove the risk of oophorectomy. There are studies comparing the excisional surgery versus ablation, aspiration and ablation of cyst wall, and the studies shown that cystectomy is probably better in terms of improving the natural conception. But having said that, one thing that we need to remember, the excision of the ovarian cyst could reduce the ovarian reserve, as indicated in the systematic review done by Francesca Raffi and Professor Swadhamar from Derby, and that is clearly showing the AMH value significantly reduced following cystectomy. And that has been shown in subsequent systematic review as well, and that is regardless of when they have been followed up. So on this, there is no solid evidence looking at association of endometrioma and spontaneous conception. But from the surgery point of view, perform the excision of endometrioma capsule, instruct drainage and coagulation to increase spontaneous pregnancy rate. And obviously, that reduces the pain, reduces recurrences, and need for repeat surgeries. However, we should counsel women with endometrioma regarding the risk of reduced ovarian function after surgery and possible use of what about surgery for endometriosis and the ART outcome? If you're treating the mild endometriosis at stage 1 and 2, if you're comparing the live birth clinical pregnancy rate, number of eggs collected, there hasn't been any difference. So that hasn't influenced the IVF outcome. What about severe endometriosis group, stage 3 and stage 4? Again, there wasn't any obvious evidence on this, although if you look here, the live birth rate, clinical pregnancy, and number of eggs collected have been slightly on the lower side compared to untreated group. What about endometrioma surgery? Again, as you see that there hasn't been any difference in terms of live birth, clinical pregnancy rate, miscarriage rate, or cancellation rate. So no difference in terms of the IVF outcome. Having said that, even when they looked at the mean number of oocytes, although there was a trend in terms of reduced number of oocytes, that was not statistically significant. In this meta-analysis, have shown that women who have had treatment for endometrioma needed much higher dose of gonadotropin for ovarian stimulation. And this similar live birth rates, the clinical pregnancy rates, have been shown in subsequent systematic reviews as well, if you've done surgery for endometrioma or not. And this, they have done further subgroup analysis looking at surgical treatment, that is cystectomy versus aspiration of endometrioma. And again, the studies haven't shown any difference in terms of the IVF outcome. So when there is an endometrioma IVF, it's always a matter of debate of expectant management versus surgical management. So we will have to look, take an individualized approach. So we'll have to look at whether are there any symptoms, are there any risk of cyst rupture? Because if the cyst is really big, there is a risk of cyst rupture and needing an emergency surgery. Obviously, during IVF, we need to monitor the ovary for how the follicles are developing, or how the ovaries are responding. So, if presence of a large endometrioma may impact the monitoring of this, it can potentially induce a poor response to controlled ovarian stimulation during IVF. And when we are doing egg collection, the transvaginal access could be difficult because of endometrioma. There is potentially a risk of infection and abscess formation because you will be putting a needle through the vagina into the endometrioma. And because the endometrioma has got blood clots and old blood, and if you're introducing bacteria from the vagina into the cyst, that can potentially develop abscess. So that need to be considered. But on the other hand, if you're doing expectantly managed, then you're avoiding surgery and associated risks. Whereas on the other hand, surgery carries side effects of treatment, post-operative adhesions. It can induce reduced ovarian reserve. In fact, one study has quoted that premature ovarian insufficiency risk is about 2.4%. So that is something that we have to counsel all young women undergoing endometrioma surgery. And it is a good practice that you do a ovarian reserve beforehand, prior to embarking on surgery. And the ovarian reserve value, as measured by either AMH or anti-follicle count, would help us in terms of counseling women. If you are doing surgery, can potentially delay the IVF treatment, particularly in the current context that any kind of elective surgery have a very long waiting time. But on the other hand, it has got the advantage that we will be able to get the cyst walls for histological information. It may improve the ECA transvaginal access to the follicles for egg collection, and reduces the risk of abscess. So to decide about for surgery versus against surgery, that needs to be guided by symptoms. Obviously, if there is a rapid growth of cyst, there is a potential risk of cancer, and therefore it is best to go for surgery. And if the endometrioma is quite large, then probably for favor surgery. If the patient has got satisfactory ovarian reserve, or
Slides are frozen.
If they haven't had any previous ovarian surgery, then that may be some factors to consider.
Sorry. Is the slides frozen again? It is, all right. Screen is off. Is that better?
For surgery. However, on the other hand,
Yes.
if somebody has had a past surgery, and if the endometrioma is bilateral, and if the egg reserve is already compromised, ovarian reserve is already compromised, then that would go against deciding for the surgery. Just a couple of slides. This is something which we do get nowadays with regard to, or at least patients ask about whether they can preserve eggs for fertility preservation, like we do for cancer patients, because endometriosis is a progressive disease, and as the time goes on, the fertility can decline. I mean, even the age-related decline happens. But women with endometrioma or endometriosis, they may have already compromised ovarian reserve, and that can further compromise and therefore reduce the chance of fertility. And this is a matter of debate, but of course, this is certainly an option of preserving the ovarian, preserving the oocytes, and that would potentially give them the chance of doing IVF later on, and then give a chance of carrying babies. There has been a nice debate published in BJOG by UK specialists for and against, and it is worth reading that for pros and cons. And this is a paper published from Spain. They have looked at the chances of subsequent conception depending on the number of oocytes cryopreserved. So as the number of oocytes cryopreserved go up, the chances of cumulative live birth rate goes up significantly. So even women less than the age of 35, if somebody was at 22 eggs collected, the chance of cumulative live birth rate is very good.
Sorry, I think somebody's mic is on. Yes, I think that's better. Thank you. So everybody, the presentation unfortunately is going on for a bit longer. Mr. Jay can join us shortly for some questions. I'm in touch with him, so just bear with us for maybe a couple of more minutes. Prof, is that all right?
So just because we're over now about 10 minutes, so I think we need to crack on with the next speaker.
Yes, yeah. So all right then.
Just
yeah, I think I can't get hold of Mr. Jay. I think he's literally just stepped out of theatres. We can, yes, I think what we can do is we can start with the next presentation.